Next slide, please. Great, and let's go next slide, please. Wonderful, thank you. Here's a brief overview of the aspects of this disease that I'm going to cover today in my talk. I'm going to start with genetics and mechanism of this disease and how it comes about. Moving on to clinical features, available diagnostic testing, the standard treatments, as well as prognosis. Next slide, please. So to dive right in, Wilson is a rare inherited disorder of copper metabolism. This was first described in 1912 by a British neurologist named Dr. Kinnear Wilson. This disorder affects approximately 1 in 30,000 people, and it's found worldwide across all races and ethnicities, and it's approximately equal prevalence among males and females as well. Although in patients who present with acute liver failure, there is a slight female predominance. The majority of patients with Wilson disease are diagnosed between the ages of 5 and 35, so it's largely a disease of younger patients, but it really can be diagnosed across almost any age. Next slide. Wonderful. So to review the underlying cause of Wilson disease, so copper is an essential metal that plays a key role in many cellular processes, as well as the development of healthy nerves, bones, and collagen. So copper is normally absorbed from the stomach and from our diet into the stomach and GI small bowel tract. From there, copper is bound to create ceruloplasmin, a protein for transplant throughout the body to where it's needed, or the excess copper is excreted out of the liver into the bile and then out of the body. And so Wilson disease results in an abnormal accumulation of copper in the body. So how this comes about is the defect is on the ATP7B gene on chromosome 13. So this encodes a copper transporting protein that's found in liver cells. And so when the function of this protein is either absent or reduced, you end up with decreased movement of copper out of the liver cells. And you also end up with a failure to incorporate copper into the functional protein of ceruloplasmin. And so when this happens, copper accumulates in liver cells, and eventually it leaks out into the bloodstream, and it deposits in other places in the body, most notably the brain, kidneys, and the cornea. And so Wilson disease has an autosomal recessive pattern of inheritance, meaning that to have Wilson disease, you have to inherit one defective copy of the gene from each parent. And there are many possible defective copies out there. More than 700 mutations in the ATP7B gene have been described, and more than 380 of these have been confirmed to have a role in Wilson disease. Next slide, please. So Wilson disease can present with a wide variety of symptoms, which can include liver issues, neurologic symptoms, psychiatric symptoms, ocular findings, as well as other notable but less common signs, which I'll mention in brief a little bit later. Many patients, when they present, have a combination of symptoms already, but those who don't often develop other symptoms as their disease progresses. Next slide, please. So to start with, as you recall from my earlier slide, the copper, the first place that it builds up is the liver. And so actually the first clinical manifestation that we often see is some form of liver abnormality or liver disease. And in fact, liver abnormalities can be seen even more than 10 years before other symptoms develop. And even patients who ultimately present with some other finding like neurologic symptoms or psychiatric disease, they often are found to actually already have underlying liver disease as well. So here, I think the major point here is that the liver manifestations of Wilson disease are highly variable. So patients can present simply having steatosis or fat within the liver. They can also present with mild liver enzyme elevations, which are predominantly usually ALT, AST. They can also present with signs of acute hepatitis, similar to someone presenting with an autoimmune hepatitis or viral hepatitis. And in some cases, the symptoms related to this can resolve, or it can develop into acute liver failure in approximately 5%. A good chunk of patients also present already having cirrhosis, which is advanced scarring of the liver. And these patients can either present with compensated cirrhosis or decompensated cirrhosis, meaning that they've already developed signs and symptoms related to their cirrhosis. So as such, the symptoms that patients present with vary greatly depending on the type and degree of liver injury. Some patients may be completely asymptomatic, and this is more common in younger patients and especially children. On the other extreme, patients can present critically ill with acute liver failure. And then in between as well, you can also see patients with very nonspecific symptoms that you may see in an acute hepatitis like malaise, jaundice, nausea, vomiting, or they can present with signs and symptoms of cirrhosis such as ascites, variceal bleeding, hepatic encephalopathy, etc. Next slide, please. So after the liver, the next most common presentation for Wilson disease is neurologic symptoms. So common ones include movement disorders such as tremors, Parkinsonism. Actually, the most common symptom neurologically that patients present with is dysarthria, or slurred or slowed speech, in other words. But they can also present with migraines, insomnia, cognitive impairment, and even seizures, although this is less common. Other common findings as well, some patients present with psychiatric disturbances. Depression is actually quite common in patients who have Wilson disease, up to 60%. But you can also see psychosis and personality changes. And I think it's important to note that these psychiatric disturbances and neurologic symptoms can actually be quite subtle, and they can actually be intermittent too, which can make recognition challenging. On the other side of this slide, we have ocular findings as well. Kaiser-Fleischer rings are the hallmark of Wilson disease. This is when copper can deposit in the Duchette's membrane of the cornea. And I'll have a picture coming up of this in a moment. And then some of the less common findings too, which can also present with Wilson disease, are things like hemolysis, kidney disorders. Patients can have skeletal abnormalities like early onset osteoporosis, as well as cardiomyopathy as well. So as you can see, very wide variability in symptoms here. Next slide, please. So these are the Kaiser-Fleischer rings that I was mentioning before. You can see what they're pointing at here is the copper deposition forms a copper-colored ring around the eye. And this is actually the same patient approximately 5 years apart after they've been treated for their Wilson disease. So these do disappear generally with time with treatment. Next slide, please. Okay. So how do we diagnose Wilson disease? So usually we're utilizing a combination of clinical features and diagnostic lab testing. Kind of the classic picture of Wilson disease is a patient who presents with cirrhosis, plus neurologic symptoms, plus Kaiser-Fleischer rings. This is kind of the classic presentation. Unfortunately, in reality, less than 50% of patients present with even 2 of these criteria. So it's actually more challenging to diagnose than this. Who should we suspect Wilson disease in? So anybody with a family history of identified Wilson disease, especially a first-degree relative, raises our index of suspicion. Also, patients who present an acute liver failure, especially if they have additional associated features. In this setting, we'll often see patients present with a severe hemolysis, also a low alkaline phosphatase, as well as renal failure. So those can kind of point us in that direction. But really, honestly, any patient who has unexplained liver disease, especially if they're younger, this should really be on the differential diagnosis. And why that is because Wilson disease is a disease where early diagnosis is key. Our goal with early diagnosis and starting treatment is to prevent the development of chronic liver disease and cirrhosis before it occurs, and also to avoid permanent neurologic dysfunction. So early diagnosis is key here. Next slide, please. So here I just have a list of some of the diagnostic tests that we use most commonly to diagnose Wilson disease. And to start off with, kind of one of the most common ones that we see used is the serum ceruloplasmin. As I mentioned earlier, people with Wilson disease fail to incorporate copper into apoceruloplasmin, and so they end up having lower levels of functional ceruloplasmin in their blood. Oh, sorry, next slide, please. Thank you. And so this is a major carrier of copper in the bloodstream. And a good majority of patients who have Wilson disease will have a low ceruloplasmin if you use the cutoff is less than 20 milligrams per deciliter. And the lower it is, the more predictive of Wilson disease it is. But unfortunately, a normal ceruloplasmin level cannot completely exclude Wilson disease. Next slide, please. So another test we use to try and diagnose this is a 24-hour urine copper test. Untreated Wilson disease, this reflects the amount of non-ceruloplasmin-bound copper in the circulation. And so this is useful not only for diagnosis, but this test is also useful for monitoring of the response to treatment. And when we do this test, copper excretion greater than 100 micrograms per day is highly suggestive of Wilson disease, although generally it's suspicious even in greater than 40 to 50 micrograms per day as well. And this does have some downsides, namely that it's difficult to use this in renal failure, as well as you can imagine a 24-hour urine collection can be very cumbersome for some patients. Next slide, please. Slit lamp exam, which is a special type of eye exam done by our ophthalmologists, can be useful too. As I mentioned earlier, the Kaiser-Fleischer rings are a hallmark finding of Wilson disease. And so this combined with a low ceruloplasmin is essentially diagnostic for Wilson disease. I should note though that these can be absent in up to 50% of people who present with strictly liver manifestations of Wilson disease. However, they're much more helpful in patients who have neurologic symptoms as well. And they're likely found in almost 100% of patients who present with neurologic findings of Wilson disease. Next slide, please. Liver biopsy is considered probably the gold standard for diagnosing Wilson disease. You can do copper staining of the tissue when you get a biopsy, although this is not as good of a test as doing an actual copper tissue concentration on the liver biopsy. So greater than 250 micrograms per gram per dry weight is diagnostic of Wilson disease, although even amounts greater than 50 warrant consideration of this disease. So this test is very helpful. Next slide. Genetic testing is also becoming more common as it's becoming more available for the diagnosis of Wilson disease. So this is testing for mutations and abnormal alleles in the ATP7B gene. It's most useful when diagnosis remains unclear despite doing extensive testing and the above tests. It's also useful when we have an inability to get a liver biopsy for one reason or another, as well as for screening, as I'll mention later. So these are kind of the typical tests we'll use in addition to clinical features to diagnose Wilson. Next slide, please. So as an overview of a treatment for Wilson disease, one of the take-home points here is that Wilson disease requires lifelong treatment unless somebody has a liver transplant. A liver transplant essentially corrects the defect. And so patients no longer require therapy, but in the absence of that, it's very important that patients are on lifelong treatment. Discontinuation of therapy in a patient with Wilson's disease can result in progressive neurologic symptoms or rapidly progressive liver failure. It's important to take a multifaceted approach to management of Wilson disease patients. There's not only drug therapy for treatment of this, but other important facets are symptom management, making sure we're adequately screening family members, management in the setting of other life changes, and then, as I mentioned, assessment for liver transplant. Next slide, please. Okay. So as an overview, I kind of think of Wilson disease as having two phases of treatment. So one is removing the tissue copper, which we generally do with chelator therapy. And two is preventing reaccumulation of the copper buildup. And that's usually achieved through also chelator therapy, zinc, as well as dietary changes. So to start with chelator therapy, when I say chelators, these are medications that bind excess copper. And so they cause increased excretion of copper out through the urine. And so usually with these medications, there's an initial treatment phase where there's a higher dose followed by lower maintenance dosing. And as you'll see, there are a couple different ones that we use. So the choice of agent is usually driven by what has this patient been exposed to, what's their presentation, what's the side effect profile. Next slide, please. So the first two are the ones to focus on here. So D-penicillamine, this was the first oral chelator that was introduced in the 1950s for treatment of Wilson disease. It's a very effective agent. and it was used for a long time with good effects. The issue with this one is that it does have a fairly significant side effect profile. You can see sensitivity reactions, kidney toxicity, cytopenias or low cell counts with this medication. And in fact, it's reported that up to 30% of patients even ultimately need to discontinue the medication because of side effects. And the important one as well is that we can see a paradoxical worsening of neurologic symptoms with the start of penicillamine. Up to even 40 to 50% of patients will experience that. So the second important medication that's a chelator is Trientine. And this was essentially kind of developed as an alternative to penicillamine because of its side effects. And so this is used either as initial therapy or it can be used as rescue therapy in somebody who develops side effects due to penicillamine. So this agent has fewer side effects, and most notably, the chance of neurologic worsening with the start of this chelator is much less than with penicillamine. And I mentioned here at the bottom too, ammonium tetrathiamaldate. This is also technically a chelator. It's been looked into in multiple clinical trials. It's thought to potentially be more effective for neurodisease, but at this point, it's still not really available commercially, still largely investigationable. Next slide, please. Next to, not technically a chelator, but oral zinc is used as therapy as well. And this is because zinc interferes with the absorption of copper. And so it has several different ways in which it can be used in the kind of the next 2 points here. So it can be used as adjunctive therapy in combination with penicillamine or Trientine. It can also be used alone in patients who are either intolerant of chelators or who have yet to develop any symptoms from their Wilson disease. And it also can be used as maintenance therapy after you've achieved appropriate removal of the copper through chelation therapy. So it has several different ways it can be used. And it's great in that it is generally well tolerated. The most common symptoms is mild GI irritation, so it's very well tolerated. And finally, not really pharmacotherapy, but I wanted to mention dietary recommendations as well. High copper foods are important for Wilson disease patients to be aware of. High copper foods include shellfish, mushrooms, nuts, dark chocolates, organ meats. And usually we'll ask patients to avoid these completely in the initial treatment phase, like in the first year or so. And then after that, once they're on maintenance therapy, they can consume these foods in moderation. And it's also important to consider things like, does this patient consume well water? Do they have copper pipes, kind of other sources of potential copper ingestion? And it's important to note as well that dietary avoidance of copper is insufficient as sole therapy in Wilson's disease. Next slide, please. I also wanted to mention liver transplant as a therapy for Wilson disease. So generally the two instances where we would consider liver transplant is a patient who presents with acute liver failure. These patients generally don't respond well to medical therapy. And also patients who present with decompensated cirrhosis that's unresponsive to drug therapy. And as I mentioned earlier, liver transplant is curative for Wilson disease as it corrects the defect. And so once they have a transplant, chelator therapy is no longer required. And these outcome numbers are potentially a little bit old here. I think the study, they're from the last transplant was in 2010, but the take-home point here is that transplant outcomes with Wilson disease are as good or potentially even better for patients transplanted for other types of liver disease. Next slide, please. And a few other aspects of treatment that I wanted to mention as well. So monitoring of therapy is very important in Wilson disease. Anybody on chelator therapy needs regular blood work, monitoring of their cell counts, creatinine, et cetera. How we mention monitor how they're doing on chelator therapy is usually done through monitoring of the ceruloplasmin and the 24-hour urine copper. And we look for the goal, a goal of between 200 and 500 micrograms of copper excreted per day in people on therapy. So monitoring is very important to identify patients who are either non-adherent to therapy or who are failing therapy. Also, it's important to take note of patients who either become pregnant or are undergoing a major surgery. It's very important for patients not to stop treatment when they become pregnant. This can result in patients developing acute liver failure. We do, however, usually reduce treatment doses in patients who are pregnant, especially early in the pregnancy. as well as with any major surgeries. We do know that these medications can interfere with wound healing as well. And then finally, screening is important as well. We know that first degree relatives of patients with Wilson disease really should be screened. Genetically, the chances of a sibling having Wilson disease is about 25%, while the chances of a child of someone with Wilson disease having it is about 0.5%. So they should be tested, and it depends kind of on what testing is available. Our AASLD guidelines recommend that siblings undergo genetic testing if available. If not, as we do with children, usually getting labs, urine tests, ceruloplasmin, slit lamp exam is kind of the way to screen these folks for Wilson disease. Next slide, please. So prognosis-wise, if untreated, Wilson disease is essentially uniformly fatal. And most patients who have this and are untreated will usually die by approximately the age of 40 or so. So, you know, as I discussed earlier, early identification and treatment is associated with a better prognosis. You know, getting treatment before somebody develops chronic liver disease, before they develop permanent neurologic damage. And overall, the prognosis is excellent for the majority who receive and are adherent to therapy for Wilson disease. The neurologic, hepatic, psych abnormalities will gradually improve with treatment, usually over the course of 1 to 2 years. Liver enzymes will often return to normal. And in patients who've not yet developed symptoms who are adherent to therapy, survival is generally comparable to the general population. Although it is important to note that neurologic symptoms do not always completely resolve with therapy. Next slide, please. Oh, and I included on here too just a few patient resources with good information for Wilson disease and patient learning. So thank you for listening.